Today, our presenter is Heidi Laurie. She's one of our senior health information auditors, and Heidi's going to give us an overview of what the audit team do. She's going to talk about the audit practice statement and some of the audits that have been done this year and some of those key findings and insights from those audits, and give us a view to what they're going to be doing over the next year. So thank you. Over to you, Heidi.
Thanks, Kath. Good morning, everyone. My name's Heidi Laurie. I'm a Senior Health Information Auditor with the Health Information Audit Team, or HIAT as we are known. I'll just introduce the rest of the team. Elise White is our team leader. Brian Stanley, who many of you will know, is also a Senior Health Information Auditor. And we also have a very new staff member having joined our team just last week, Daniel Walsh, Health Information Auditor. Our fifth team member is also a Senior Health Information Auditor, is currently vacant and will be recruiting for that position in the near future. So a little bit about our team. We are all health information managers with experience in audit, and we also hold board experience both at the department and within the HSP environment in areas such as classification, management and nursing. So where do we fit in? We belong to quality assurance, along with WACA, who you just heard from, and also data quality. And we collaborate with both of these teams very closely. We also liaise heavily with the data custodians for each data collection, for example, on policy guidance during the audit data collection phase. And we also refer areas of non-compliance to them for resolution with the HSP. Our audit practice statement, or APS, is a supporting document within the PAD policy and governs our entire function. The APS outlines audit processes and practices, and they're generic to all types of audits. There are seven elements to our APS. Firstly, our purpose. At its core, our audit program has a dual purpose, one being to assess compliance with mandatory policy, as is the case with the PAD policy, and secondly, to provide objective assurance of the quality of the patient activity data that's actually reported to the department within each data collection. For every audit we conduct, the criteria can always be linked back to the data and its collection against mandatory policy. And through our audits, we assess risk and make recommendations for improved compliance. Our scope is to measure WA Health Service entities' compliance with our biannual audit plan, and audits can be conducted by assessing medical records at hospitals, although this was paused in February of this year due to the COVID high caseload. And audits can also be conducted remotely from the department by accessing digital or scanned medical records. Our audits are generally scheduled. However, we also respond to emerging issues and identified risks with ad hoc audits. We operate under 7 principles of audit that are detailed on this slide. Of those, I'd like to highlight confidentiality, as we're often asked how we maintain it. So we only access medical records we audit and store only unit medical record number level data. As with any audit program, we do audit within limitations. Our team does exercise professional judgment when required. However, as our team has many years of experience, as outlined earlier, we are confident in our professional standing and incorporate robust team discussion in every audit that we conduct. We are also limited by sample size. As auditors, our aim is to define a sample which is representative of the total population, and we use several sampling techniques to support fair depiction of the population. Our audit procedures, which are also listed on the slide, are extensive, and the process is well defined and documented in the APS. The main points I'd like to highlight here are the value and importance we place on open and transparent communication between us as a team and with you as HSPs. Part of our role is to support you in the identification of non-compliancy and assisting with direction for improvement strategies. Our focus during audit is on assessing data collection and documentation of patient care to support that data. We are not reviewing or making any kind of assessment on clinical decision making. The APS clearly defines the responsibility of WA Health Service entities and the department, including engagement entry agreements in the lead up to, during and post audit, including action of any recommendations. The final element of our APS is the quality assurance program. This extends to professional development of us as team members and also the ongoing review of the audit program, which in part is supported by the annual consultation and review process of the APS, which was just recently completed for 22-23. Based on the feedback we received from you, the major change we made is to the timing of the exit interview. This used to be completed straight after the data collection phase, but we have now moved it to after the draft report is completed to support more meaningful discussion on audit findings. So this is a summary of our audit program for 2021. As you can see, we have been really busy over those 12 months. We conducted over 50 audits, reviewing over 4,500 episodes, from which 80 recommendations were made with 110 actions completed. Our largest number of audits was related to the hospital morbidity data collection. Some examples of the audits in this area is our long-standing DRG audit program, where the accuracy of DRG assignment is assessed. And we also expanded our scope in this collection to new subject matter. For example, the review of admissions to ED short stay units to determine if they met the criteria for admission, specifically looking for stays that are either under 4 or over 24 hours. The team also audited unplanned return to theatre episodes for the first time. This audit reviewed the accuracy and reliability of data recorded in the Theatre Management System, or TMS, and WebPAS, as this data is used to calculate the performance indicator for unplanned returns in the WA Health System's Performance Policy Framework and for HACCES. We also audited care type changes across several data collections, so within the HMDC, subacute and mental health data collections. And we assessed if these episodes met the mandated authorisation and documentation requirements. Our findings have affected changes to the admitted patient business rules, as outlined by Bernard earlier. In the ED data collection, we audited data that is used for the WA emergency access target, and the team also conducted new audits within the midwife's notification system, reviewing preterm births and the documented reason for induction or caesarean section, and see if that was correctly reported to the M&S. Just to look at some of the results and insights from our audits in 2021, this slide shows the WA average for DRG accuracy rates from 2017 to 2021. There was a reduced number of audits from 2018 to 2020 due to our team's restructure. However, it's great to see an upward trend in the average accuracy happening there again. Other audit insights and their significance. Some of the non-compliant issues highlighted within the HMDC was the lack of a medical record definition. So that meant that it was unclear as to what could be included as medical record documentation, which caused variance in data collection. So this definition, as you heard earlier, has now been added. Another example is compliance with the PAD policy requirements for same-day Type C procedures. These were consistently low across HSPs, and the PAD policy business rules have been updated and the use of edit validation is being investigated. Within the theatre management system, lack of business rules were identified, resulting in inconsistent data collection. So the PDMO is assessing the requirement for the development of these business rules. And for the mental health data collection, the collection of the Health of the Nation Outcome Score, or HONOS, and the phase of care for mental health admissions was identified as being inconsistent. So they've now been included in the PAD policy 2022 as mandatory items, so that all episodes can be grouped accurately in the Australian mental health care classification. So looking at the rest of our audit plan for 2022, as mentioned, audits at hospitals were paused earlier this year. However, we've just been advised that we can again commence these in August. So we're picking up many of the audits that we had to postpone at that time. In the next 6 months, we'll be looking at the regular DRG audit program, as well as continuing with other audits such as the EDSSU, unplanned return to theatre, and 2 new audits of interest, including reviewing coding of COVID-19 admissions and assessing episodes of patients who did not wait and who discharged against medical advice. We'll also be continuing the care type and classification audits within the mental health data collection. New audits will also be conducted in the non-admitted patient data collection for the first time, where we'll be looking at reviewing the collection of data elements both in the tertiary and secondary HSP environment. Ad hoc audits will continue to be completed to address any emerging issues or identified risks. And looking to the second half of 22-23, future audits earmarked include obviously the DRG audit program, M&S and WA emergency access target audits, contracted care, hospital-acquired complications, both of which are new audits. And we are really looking forward to be able to complete audits at hospitals once again and to new audit subject matter for the next 6 months. Thank you for joining the audit team, and I'll end our presentation with our contact details, which are on the slide there. We're also on Global. In closing, I'd like to highlight again that we have a vacancy in our team. So if you found hearing about our work appealing, please feel free to contact us and we encourage you to apply. Thank you. I'll hand back to Kath for questions.
Thanks, Heidi. That was really interesting to see how the role of the audit team is evolving from what used to be more inpatient DRG audits to, non-admitted emergency department, and supporting the quality assurance of some of those performance indicators, which again is a good application for patient safety and quality. We do have a couple of questions for Heidi.
Sorry, Kath, before we move on to that, I just would like to clarify, obviously, COVID is an ever-changing situation for all of us. Once again, we find ourselves in that situation. So where it has been earmarked as going out to sites again in August, that's an evolving decision based on the current climate. So
anything could happen in that space.
Yes, that's right.
That's for sure. Yeah. A couple of questions that people have sent in. Does the audit team have like a target number of audits they have to do for each health service provider?
That's a great question. We actually asked that quite a bit. We don't have a set number of audits to complete for each HSP. Our DRG audit program is cyclical, and the team tries to audit larger hospitals annually, smaller hospitals less often. So it just depends on when you were last scheduled in the audit plan. And other audits are based on, as I mentioned, emerging issues and risks identified by either stakeholders or from within ISPD. So the time frame for those does vary as well.
And we had another really good question. Can the audit team please come to a hospital and do a local audit for us?
We generally do, as I mentioned, planned or scheduled audits. Certainly, if you do have an issue that you would like investigated or assessed, you can always contact us and we can have a discussion with you within our team, within ISPD, and then perhaps look at building in your audit to our schedule. We generally do have a set plan for the 6 months, but we're always, as I mentioned, we're here to assist you with areas of non-compliance and strategies for improvement. So you can always approach us.
Great. Thanks very much, Heidi.
Thank you.
So next stop on our journey is the